Thank you. First of all, just a brief introduction to Merrimack. We're based in Cambridge, Massachusetts. We have over 400 employees now. We were founded about 15 years ago, and we have over 10 large molecule programs in various stages of development. About a couple of months ago, we received FDA approval for our first therapeutic in Onivide, liposomal formulation of irinotecan for the treatment of pancreatic cancer. When we started 15 years ago, we turned to computational biology to really help us better understand the signaling networks driving disease, specifically cancer. Over time, we've turned to these computational modeling to not only help us understand the biology behind disease, but also to design therapeutics, as well as to identify biomarkers that we're co-developing as companion diagnostics with all of our therapeutics. Shown here is a snapshot of our platform. We have a variety of different molecules in different phases of development. The one that I'll focus on today is MM-121. It's an anti-HER3 monoclonal antibody. When we took a close look at the HER or ERB network signaling pathway years ago, we stumbled upon HER3 as being a key node in that pathway. HER3, in combination with its ligand heregulin, binds other cell surface receptors and in concert activate signal transduction pathways that lead cells to be non-responsive to other therapies. Realizing this, we developed MM-121, a fully human IgG2 antibody that blocks the binding of heregulin to HER3. And because of the importance of heregulin in identifying those patients that we think are most likely to respond to MM-121, we're also co-developing a diagnostic for heregulin that I'll talk more about. Quickly, preclinical data, representative of many different experiments we've done in different cell lines with different chemotherapies, showing the response of cell lines through cell viability to chemotherapy. If we add heregulin into this mix, the cells lose a capacity or have a diminished capacity to respond to the chemotherapy. If we add in MM-121 with heregulin, the cells then have the ability to again respond to the chemotherapy. One xenograft model, a lung cancer xenograft model in combination with paclitaxel, we see minimal impact of paclitaxel alone, some impact of MM-121. The most effective combination is MM-121 plus paclitaxel. We see this impact not only when MM-121 is added at the beginning of treatment, but also when we add it later after tumors have been exposed to paclitaxel alone for a month. So we think heregulin mediates resistance to a broad range of therapies, and that MM-121 blocks this and restores sensitivity to therapy. And we think this is probably through its impact on downregulating HER3 as well as blocking downstream signaling. So we turn to the clinic, and what I'll focus on today are three different phase 2 studies that we've now completed. One in ovarian cancer in combination with paclitaxel, one in breast cancer in combination with exemestane, and one in EGFR wild type lung cancer in combination with erlotinib. First, the lung study. This study was in EGFR wild type patients that had no prior exposure to TKIs. Shown here is the results looking at progression-free survival in the overall population. Obviously, the addition to MM-121 or erlotinib had no significant impact on the progression-free survival of these patients. So we turn next to our biomarker hypotheses. Prior to this study, we had pre-specified a number of different analyses, biomarker analyses that would be performed on samples collected from these patients. And these include three different receptors and two different ligands that we thought were critical. So now here, if we look at just the control arm patients of that study, those patients with the highest levels of heregulin responded most rapidly to erlotinib. And those patients with lower levels of heregulin responded, had a better response. Now, if we look at those heregulin positive patients, we see that MM-121 may indeed extend the progression-free survival in heregulin positive patients. We saw similar trends in the other two studies that I'll just show very, very briefly in breast cancer and ovarian cancer. In all three of these studies, we see that I'm going the wrong way. In all three of these studies, we see in the overall population no impact of the addition of MM-121 to the standard of care therapies. However, as was seen in the lung cancer study, patients with high levels of heregulin in both breast cancer and ovarian cancer also progressed rapidly on the standard of care therapies. And when we add MM-121 to the standard of care therapies to heregulin positive patients, we see potential benefit to these patients. Overall, the heregulin positive population, we think it's about 50%, give or take, in all the different tumor types we've looked at, both in these clinical studies as well as in a number of different tumor surveys that we've done. Overall, we have a fairly large safety profile on MM-121 now. It's fairly well tolerated. We do see an increase in toxicities upon the addition of 121, but we found these to be tolerable and well managed in the clinic. So we think we've identified heregulin as a major biomarker for MM-121. And though the number of patients in these subsets analyzed across the different studies indeed are small, what's encouraging to us was that we saw similar results across 3 different tumor types in combination with 3 different standard of care therapies. What I didn't show you is that we have also done an extensive PK analysis that supports weekly, every other week, and every 3-week regimen for dosing MM-121. So now quickly onto the diagnostic. Because of the importance of heregulin, we're developing a companion diagnostic along with the development of MM-121. We've turned to in situ hybridization as our preferred platform, and we're using technology out of Advanced Cell Diagnostics to develop that. We now have a fully automated protocol on a globally available platform. A scoring system's been defined, and we've worked pretty hard so that a number of different tissue samples are acceptable, including fine needle aspirates, core needle biopsies, and surgical resection. We have extensively analytical validation of the assay that I won't go into. We've met with the FDA, who's in alignment with our regulatory path forward. We've now transferred the assay to CLIA-certified labs, trained pathologists there, and those labs are now performing the assay for us to prospectively select patients in our future clinical studies with a 7-day turnaround time for reporting out results. This is just a visual for what the assay looks like. We score a minimum of 50 tumor cells. If at least 10% of those tumor cells express heregulin, we then assign a score of 1+, 2+, or 3+. All of these are deemed heregulin positive. And in our current study that I'll talk about in a minute, these patients are being enrolled. So just quickly to wrap up, this is the current phase 2 study in heregulin positive non-small cell lung cancer that we just initiated earlier this year. All patients are being screened using a pretreatment tumor biopsy up front. Heregulin positive patients are enrolled into a treatment group. The chemo backbone is selected by the investigator to be either pemetrexed or docetaxel. Those patients are then randomized 2-to-1 to receive either MM-121 plus chemotherapy or chemotherapy alone. So with that, I think I will close.
Is there any, for heregulin, is there any clinical characteristics that you've seen so far that may predict for patients who express this, like they're, again, like we've seen some things, we know that non-smokers are more like EGF, or
right.
Is there anything that you've seen? I know you have small numbers so far, but anything that you kind of have any idea?
We don't. We don't yet. And as you said, we have small numbers at this point, but we haven't seen any significant correlation with other things that we've looked at.
Not a question, but a comment. It's interesting to see you are introducing the mRNA in situ assay, which is, in my opinion, a very interesting and feasible assay. My lab is one of the certified labs from advanced cell diagnostics to do this, and we have very encouraging results for PD-L1 among other biomarkers with this particular assay. So it will be very interesting to see you pursuing this in a regulatory pathway.
Yeah, thank you. Yeah, we've been very, very pleased so far with the performance of the assay and development of it.
Yeah, I just want to second that I think an RNA-based assay is really exciting, and getting that into, and I think there are a lot of people thinking about platforms that would be acceptable on the RNA side, because there's so few machines that are in CLIA labs that are acceptable, and in situ is, that's an elegant strategy. So
Yeah. Thank you.
Yeah.